All righty.
Good afternoon. Welcome to Grand Rounds today. Thanks for signing the attendance record at the back of the auditorium, and also please fill out and return the program evaluations that hopefully you all picked up on the way in today, and in particular, if you have any thoughts in regards to future topics or future speakers, the CME committee is always appreciative of those. Today, it's my pleasure to actually reintroduce Thyra Cox. She holds a Master of Science in Nursing and has certifications in several other areas, including as a diabetes educator, a certified health coach, and a certified NDPP lifestyle coach. As you may recall, she was here not too long ago to educate us on pumps and glucose monitors, and she has kindly accepted our invitation today to let us know what we can do to stop, slow down, or manage type 2 diabetes mellitus. And please join me in welcoming Thyra Cox.
Thank you. Good afternoon. Appreciate the opportunity to come talk about a program I'm quite passionate about, so I'll try not to get too excited about the diabetes prevention program. Move on here, and our objectives are listed up there. We want to start by identifying what is the difference between prediabetes and diabetes, recognize and value the benefits of the diabetes prevention program. Number 3 is understand the difference between the Prevent T2 and the Medicare diabetes prevention program, both of which are offered at Mary Greeley Medical Center, and to understand the services provided at MGMC's Diabetes and Nutrition Education Department that are outside of the diabetes prevention sort of realm. So we will jump right in here. I want to start by just sort of setting the stage for why this is important. This is a slide that talks about the storm, and you'll see this is from 1958 to 2015, and I'll see if I can run my little thingy, yeah. So it starts over here in 1958, and this is showing us the yellow is the percent of people with type 2 diabetes or diabetes overall, and then underneath it is the raw number of people who have diabetes. So you can see that over the course of this amount of time, we've had a significant increase in the number of people who are diagnosed with diabetes. And then this slide, I believe, was shown probably about a year ago, maybe, when the gal from the Iowa Department of Health came and talked about the diabetes prevention program. But again, it's it really tells the story of what's going on in our country and why this is important. This has to do with the age-adjusted prevalence of obesity and diagnosed diabetes among U.S. adults. And we see in 1994, the scales are exactly the same down here at the bottom. And you can see that the obesity in our country, we had pockets that were a little heavy, and some places, heavier than those, and then places where it was actually fairly low prevalence of obesity at that time. And same thing with diabetes. Again, we had this one, I don't remember, state that had higher incidence, but certainly, what was thought to be pretty reasonable. And then we go over here to 2015. And that's 3 years ago, so when the next data set comes out, we're probably going to see even worsening colors. And you can see our obesity has just dramatically increased to the point where we've got many, many states greater than 26%. And along with that, we see that same trend with the incidence of diabetes. And then the next slide, this was a recent statistic that just came out in, I think it was the end of August, early September. And this particular slide, what jumped out at me when I saw this information was that they're talking about Iowa. And surprisingly, or unfortunately, I think is a much better word, we are now in the category of 7 states that now have obesity rates of greater than 35%. And it's the first time Iowa was in that group of states. There are some states, more southern states, that have been sort of struggling with this for a long time. Another statistic was, as of 2012, there was no state that had an obesity rate over 35%. So adult obesity rates are significantly increasing in the United States, and in particular, these 6 states had very significant increases. In Iowa, we have 36.4% of adults living in Iowa have obesity, and we now rank 4th in the country. So not really something you want to brag about, but it certainly sort of segues into why the diabetes prevention program is so important. So why does it matter? Well, obviously it matters because we've got this problem that's going on, but also here's some statistics for you and just points of information about prediabetes. So obviously prediabetes usually is a strong predictor for type 2 diabetes. 1 in 3 American adults have prediabetes, which is pretty striking when you think about it. If you were in a room with people and 1 of every 3 people had prediabetes. 25% of adults over the age of 65 years of age has prediabetes. Most people do not know they have it, and I would say that's definitely what we see when people come to us and they think maybe they have it. They didn't know they'd had it. When we look in their medical record, we can see elevated numbers that indicate they've probably had it for a significant amount of time sometimes, and they were never really aware of that. And I think that's just some of us, you know, part of the change in how we look at this, that we want to start looking for those numbers much, much earlier. And diabetes can be prevented or delayed with a prediabetes lifestyle intervention. So what are the costs of ignoring prediabetes? Research shows that people even in the prediabetes state have all of these conditions that are listed over here on the left. So they will present oftentimes, while their numbers are not actually in the diabetes range, already having some of the complications occur because of those elevated glucose numbers that they are experiencing. And up to 27% of people with prediabetes will develop type 2 diabetes within 3 years. So the conversion rate is pretty, pretty significant when you think about it that way as well. What are the patient costs for having type 2 diabetes? So if we can kind of slow down the train or stop it, how does that impact people, real people? Obviously, when you have type 2 diabetes, you're more at risk for missing work, having to go to doctor's appointments, having issues related to the disease itself. If there's no treatment, and again, these are kind of bold statements, but obviously if someone has no treatment, they're going to have 100% more likely to develop hypertension and 70% more likely to die from heart disease or stroke. The risk of premature death is definitely increased significantly as well. If you have prediabetes, you don't even have to be in the diabetes category yet, and the risk of death increases. And costs are very significant. And I know all of you who see patients day in and day out are seeing how the changing landscape of health insurance is impacting people. And this is a disease that impacts people significantly when they have to go on and on and on up the chain of different medications that are utilized for type 2 and type 1 diabetes management. And then lastly, those with prediabetes and diabetes are twice as likely to battle depression than those without. That was from a study done that came out, I think, in 2016. So let's talk a little bit about the actual prevention research, because the research is really what's driven this program to be fairly rapidly move forward in the United States. Generally, we don't have, for example, Medicare move anything very fast, but the research on this has led Medicare to actually very rapidly approve and move into actual coverage for patients in a very short amount of time, the diabetes prevention program. So the original study is actually, I kind of listed them in the wrong order, but the Day-King Diabetes Prevention Study has over 30 years of data showing that lifestyle intervention, doing the things that people are taught through the diabetes prevention program work, and that they help to slow the disease down, prevent it in many people, even over the course of 30 years they're finding. So that's pretty significant. And the other thing they're looking at now is really looking at what happens to these people's cardiovascular risk. So they're not really looking at diabetes anymore because they've already basically proven that it works. What they're looking at now is if we put people in this program, what happens to the other problems they might have along with diabetes. And people's cardiovascular risk is significantly reduced. So up at the top, you'll see for the first study in the U.S. was called the Look Ahead study. And the Look Ahead study showed that after 5 years, the incidence, so there were 3 arms in the study, just briefly. One was a metformin arm, one was a lifestyle intervention arm, which is the diabetes prevention program, and the third arm was people who were in the same risk, but they didn't receive anything. They just went on their lives as they had been. And so what the study showed was that there was a 58% lower incidence of type 2 diabetes after 5 years for the people who were in the lifestyle intervention. There was a 31% reduction for those in the metformin arm, so it definitely worked. And then the big statistic that, and again, this is why Medicare jumped on this right away, is that there was a 71% reduction of those for those aged 60 years and older, which is really a big number when you think about it. So it really works for people who are a little bit older. 10 years after the intervention, they looked back again, and 33% of the participants in the lifestyle arm were still diabetes-free. So they still were having a fairly good result from that after 10 years. And then 15 years after the intervention, those in the lifestyle intervention, 27% were still free of type 2 diabetes, and metformin still was working for some folks at about 18%. So the research is very strong supporting the program. The program itself has very high quality standards, and it's probably why I get so excited talking about it, because our program has been in existence for about 2 years, and we've been able to meet all of the quality standards both the CDC and CMS have set forth, and we are a fully recognized program for both of those types of programs, and that is not easy to do. So I'm pretty proud of our staff who've done this, and also our participants who've really jumped in and become part of this and engaged in it. So we have met the standards, we're fully recognized, and we do offer both the Prevent T2 and the MDPP, which are the 2 different types of programs. So let's talk a little bit about what is prediabetes. Most of you probably know what prediabetes is, but just to review, here is the criteria right here for the Prevent T2. You're going to notice that I talk about these 2 separately because there is a little bit of a difference with the Medicare program, what the requirements are. And then let's move forward. And here's our risk screening. And I did leave copies of the risk screening in the back, so if you want to take one with you, you can do that. It's on the ADA website as well, and the CDC also has a risk screening tool. So this is the criteria that for Prevent T2, people also can be eligible for this program if they meet a score of 5 or more on this risk test, because that is indicative that they probably are going to be at high risk for type 2 diabetes. So you can see quickly, how old are you? Are you male or female? If you're female, did you have gestational diabetes? Because that kicks up the risk some. Do you have a mother, father, sister, brother with diabetes? Have you ever been diagnosed with high blood pressure? Are you physically active? And what is your weight per this chart over here? And they add the score up, and then if it's 5 or higher, then they would be at risk for type 2 diabetes and eligible for the Prevent T2 program. So the structure of the Prevent T2 program is it's a 12-month program. We follow the CDC's curriculum, and we're using their second curriculum, which is called Prevent T2. Not very original sometimes. Everybody must meet certain criteria to be in the group, and they must come to a session 0. So we are going to be starting a group in November, and so we're advertising right now that people should contact us and set up a session 0. During the session 0, we spend some time with them and talk to them about all that's required of them to be a participant, because this is really an investment in people's time and energy. And if it's not the right time in their life to do it, then they should wait till they actually have the time to participate fully so that they can get the benefits from the program. The program includes practical training and long-term dietary changes. So there's a good section on eating habits and how we can change those to help our bodies be healthier. Another stressor is on physical activity, and then behavior change that leads to weight loss and lifestyle change. And I would say this is sort of the hidden gem in this program and how the curriculum is written. because through the group sessions, the behavior change happens. And that is obviously what's going to help people be able to sustain and continue with the changes they make while they're in the program. It's easy maybe to do it while you have people supporting you, but what happens when you're out there alone? And it's that behavior change process that's so important to that. And then you get group support. I would say most of the groups have a lot of fun together and get to know each other, and they support each other. Okay, so let's now switch gears a little bit to talk about the Medicare prevention program, and it is slightly different. As I said, we are fully recognized, and we were the first in Iowa. We're actually one of the first in the whole country that was able to be fully recognized. So that was pretty exciting. When we looked at the map and there were like 3 people, and we were one of them, that was like, that's pretty exciting. So the Medicare DPP lab criteria, as I said earlier, is a little different. So you will notice that for fasting glucose, for whatever reason, Medicare decided to have a little bit higher number. These numbers are exactly the same as the other groups. I don't know why they did it. They never gave any explanation. I suspect it was a way to maybe decrease the number of people who are eligible. But they can have an A1C the same as anybody else, and the likelihood is that they're going to if they have elevated numbers. So it hasn't really been a big problem for us to find people who are eligible. So those are the 3 blood tests, and it does have to have been done within 12 months of their first core session. So this eligibility is a little more controlled than the other folks. Eligibility also includes that they have to be a Medicare Part B beneficiary. So if they never bothered to sign up for Medicare, they can't, even if they're a Medicare age person, they can't actually be in the program because they don't actually have the benefit of having it. The Medicare Advantage programs do offer this, but it's a little bit different, and we're just now starting to get contracts with them to be able to offer it to those people too. Obviously, they can't have a diagnosis of type 1 or type 2 diabetes if they're going to be in the program. They can have a history of gestational diabetes, as I said earlier, and they can't have end-stage renal disease, and they cannot have participated in the MDPP previously. So right now, this program just started in April, so we really don't have to worry about that, but as the years roll by, that will be something we will have to track because they can only come through this program one time. And the structure is a little different. The first 6 months, they have 16 core sessions, and I would say generally we took the approach that our goal is not just to run people through this program. Our goal really is to make sure people are successful, and so we actually offer more than what the program requires us to offer because we feel like that is how people can actually get the benefits of the program. So we offer more sessions because we found early on that people needed that continuity early on to really get into the program and move forward. The second 6 months is monthly, which is true for both programs. And then the big difference between the two is that people in the MDPP program actually get a second year of services. So they get that if they have sustained the 5% weight loss and their activity level, and they have come to a certain number of the sessions. Then they are eligible for an entire second year of support and monthly meetings. Originally, Medicare actually was saying that we would have to provide that for a total of 3 years, but they kind of backed off on that because most programs said that's not really financially feasible for most of us to do that. So we'll see how that goes. We just have one group that's a Medicare group at this point, so I don't have a lot of outcomes from that group. Again, the Medicare, both the programs, the goals are the same. So the 2 major things that we want to work on with people is we want to get people to lose 5% of the body weight that they start out at, and we want to get them to the point where they are at least getting 150 minutes of physical activity each week at a moderate pace or more. And again, I'm speaking to a lot of people who are already well aware that many people do not get that kind of activity and that that's a problem for them. So we've got to really help them to move in that direction. The goals basically for the post-core sessions are to maintain any weight loss that they've had, because that's usually what's the hardest thing. It's easy for many of us to lose weight, but it's hard to maintain a weight once you've gotten some weight off. So it's helping people to do that and to keep working towards their weight goal if they haven't reached it, and to continue with their activity each week. The cost of the program right now is $500 per participant for the Prevent T2 program. And we do have several insurers, Mary Greeley and McFarland, both decided early on to offer this to their employees if they were carried under their medical insurance plan. And then other insurers in the state of Iowa are also starting to have it as part of their policies. We do expect that there may be a fairly significant increase in 2019, as Medicare has now stated that they will cover it, and oftentimes private insurers follow their lead. So time will tell on that. For Medicare recipients, look at that. Medicare doesn't do this very often, do they? That was one of the best things about this program when they finally laid out how this was going to work. Medicare recipients don't have to pay a copay. So there are no barriers financially for anybody to participate in the program. And that really does help. Many Medicare recipients are in tight budgets and have to worry about things like that. So that's been a win for everybody. These are the goals, these are sort of our outcomes thus far. I call this goals met, lives changed, because truly, if you have the opportunity to talk to someone who's gone through the program, you will find that most of them will tell you that it really was very life-changing to be part of one of these groups and go through the program. And I know there's a number of people in the audience who have been in the groups. But hard data is that we've had a weight loss for all of our participants of 5.5% of their body weight. For 6 months, the average is 10 pounds. At 12 months, the average is 12 pounds. Activity minutes is just amazing. 267 minutes is the average number of minutes that the folks who have been in this program have been active. And they are creative at their activity, which is part of the wins. Is I don't just have to go to a gym, because a lot of people don't want to go to a gym. So it's helping them find ways in life to be active, and that then can be actually realistic for them. Improve quality of life, and about 8.6 people or participants are in each cohort. So each group is called a cohort, and that's how many on average we have in our groups. Other benefits, this is a fairly new study that I found that showed that the cost of, this is national data for Prevent T2, and the cost is between $400 to $500 across the US. The employer savings, so this study was looking at what is the benefit for an employer to actually provide this to their employees as a benefit, and what they found was the potential savings over 3 years was up to $35,000 per person that was enrolled in the study. So pretty significant cost savings, and the return on investment in 3 years was up to 42%. Medicare also did a cost analysis of what their savings potentially can be, and their first year estimates are that they expect to save $180 million by providing the MDPP program. So pretty significant. So next, and I think we should have plenty of time for questions, so I'm going to talk just a little bit about the other services that the Diabetes and Nutrition Education Department provides at Mary Greeley, because sometimes people think we're just about diabetes, and we actually do a lot of other things, so I just want everybody to be aware of that. So I'm going to start by talking about DSME and MNT, which are acronyms for Diabetes Self-Management Education and Medical Nutrition Therapy. So we offer both of these at Mary Greeley. And this slide is, there was a collaborative effort by several large bodies, the American Academy of Clinical Endocrinologists, the American Diabetes Association, and the American Dietitian Group, which I can't think of the name of the other part of it, but they all got together about 2 years ago, and they really looked at why aren't people referred to diabetes education? You'll notice over here, only 6.8% of individuals newly diagnosed with type 2 with private insurance participate in DSME within 12 months of diagnosis. Okay, 6.8%. That's not very many people when you think about that. And down below, you'll see Medicare statistics, which shows that only 4% of Medicare participants receive diabetes education or medical nutrition therapy annually. 4%. So you can see that there's a lot of underutilization of these two programs. So I wanted to just at least explain a little bit what these three groups came up with as times when people should be referred for these services. So the first one is anytime someone is newly diagnosed. And research, I don't cite the research here, but the research is very clear that people who are encouraged and enroll in a diabetes education program their first 12 months at the time of diagnosis, their trajectory of disease generally, obviously we have outliers of people who the disease just ramps up very quickly, but the trajectory is very, very much improved for those who have diabetes education. So you really have to ask yourself, why aren't people getting diabetes education? Because that's really, over the course of that next 30 years they have the disease, that's going to make a big difference for them. Annually, for health maintenance and prevention of complications, people should be referred. So let's say they've had diabetes for several years. They saw the educators initially, and then they kind of just got busy and forgot to go anymore. It's still good to get them back in annually for sort of a refresher course. People forget a lot of things. I mean, we're all human. We've all learned new things, and we're like, I'm going to do that the rest of my life. And what happens? I mean, it's easy to kind of get back to our old ways. So coming to see an educator helps them to refocus and remember the things that are important. And diabetes management changes. You can ask Dr. Riva and Dr. Carino that question, and they'll tell you, I mean, in the last 5 years, we've just had huge changes in how we actually manage people with type 2 diabetes, and type 1, for that matter. Anytime someone has a new complicating factor, so that might be if they've started to have wounds, if they've started to have hypoglycemia, those types of things, then again, meeting with a diabetes educator or a medical nutrition therapist is going to really help those people get on track with that. And then the last bullet point shows anytime a transition in care occurs is an appropriate time for a referral for diabetes education. So, oops. Oh, sorry, pushing my buttons too fast. So I'm actually going to skip a slide because I realized I should have put this one first before I talked about my last couple things. So coverage is usually one of the big reasons people cite as why they won't come have diabetes education. And I feel like I am so lucky to work at Mary Greeley where coverage is not a barrier. So my message for all the providers is please encourage people to call us and talk to us, and we will work with them to find a way so that it isn't a barrier for them to be seen for diabetes education. We offer financial assistance. Mary Greeley will work with people with payment plans. There's simply really no reason in my mind that we can't see someone. They may still struggle with it. We all know there's a lot of deniabetes, which is saying, I don't have this, I don't really have to do anything because it's not really me who has this disease. But when it comes down to one of the biggest barriers, please make sure you encourage patients. And if you want to tell them to call me and talk about it, I'll be happy to talk to them about it, because we simply don't want that to be a reason why people can't get the help they need so that their diabetes is managed and they feel comfortable with what's going on with that disease. Our biggest problem, really, and I'm sure all of you are seeing this too, is these high deductible plans. And from what I'm seeing, that's just going to continue. More and more people are going to have high deductible plans. So when they come in, they might get a bill from us thinking that they didn't have coverage. In reality, they have a high deductible plan, and they have to meet their copay before they're going to have their insurance company pay anything. And that shocks people, and they don't understand how their insurance works. So again, please encourage people to come. We strive to have the lowest pricing if someone does have to do cash pay. Mary really wants to be the lowest in this whole area for someone to come for care. So encourage people to come. And like I said, I'll work with them and help them to come up with a way to make this work. All right, so back to our other services we provide. And this is just a large list of everything we do. Obviously, we take care of type 1 patients, type 2 patients, gestational patients. We take care of eating disorder patients, which is one I forgot to put up here, so I wanted to make sure I mentioned that. Many, many patients now are on continuous glucose monitors, either their own or a professional version, which we put on them. And I'm sure all of you are seeing the TV ads for the Dexcom G6 and the Libre View. Those versions, which we didn't have last spring when we talked about them, no calibrations, no blood sugar testing. So people want those devices, and they are pretty life-changing for people to be able to wear. So we've been pretty busy with those. We do insulin pump training and management, nutrition counseling. So that's just going to be for someone who maybe is struggling with a disease that's causing them to have eating problems. You know, maybe they've lost too much weight and they need someone to help kind of figure out how many calories they should eat to get back to a healthy weight, a variety of things. Cancer nutrition and Go Red nutrition counseling are services we provide as well at no cost to the individuals who are eligible for that. The last one up here on this slide is the Better Choices, Better Health program, and you may have seen the brochures for that. This is a new program we are offering for anybody who has one chronic disease. If you have patients who are struggling with managing their disease and living with that disease, this program is being offered, and we don't charge for this program. And from what we're seeing with this program, we just started this program, I guess this summer was our first group. It's very powerful and very helpful to people. So if you have anybody in that category, please have them call us and we'll kind of fill them in on that. It's a 6-week program. And then last, the inpatient dietitians who are now part of our team, they are providing services to patients who are in the hospital and need help with their diets, and they do great work. They kind of hide behind everybody else, but they actually impact patients every day. So we're very happy to have them as part of our team. We run the Mileage Club, which anybody who has younger kids or had younger kids in the Ames schools and Nevada schools and the surrounding area. This is a program where we want to really get kids active and make it fun so that it lays that pattern down for the rest of their lives so they won't be in the category of people who aren't active. This morning I got on my listserv a little blip that said that 25% of children, only 25% of children in the United States have 1 hour of activity daily. And that's pretty alarming. And it's probably going to contribute to those numbers we looked at the very beginning. So we've got to find ways to change how we are living as a society. And the Mileage Club has been a great program for that. The Hegstrom Symposium is offered annually, and this year will be the professional component. I don't have a date or a topic yet to share, but it will be coming in the wintertime probably again. And then we also do dietary evaluations for all the cardiac rehab patients that come through that program and assist them. And then we have, I put registered dietitian resources for the summer food program, but really any of the educators in our department, we go out into the community and provide free programming. If somebody wants a speaker to come talk about whatever the topic might be, if it's related to nutrition or diabetes or prevention of diabetes, then we go out and do that. One of our dietitians worked with the Nevada cross-country team this fall, and those kids really got a lot out of that. She provided some great information for them. So we do a lot of things in the community as well, and that's really part of the mission at Mary Greeley. We're lucky to be a department that really gets to see that play out and make an impact on those things. So I think that's all I had. If you have any questions, I'd be glad to answer any questions you might have. So her question was, do we have brochures? And I left some up in the back on the Medicare Diabetes Prevention Program and the Better Choices, Better Health Program. We're out currently of our Prevent T2 brochure. But if you want them, my email is cox@mgmc.com, and you can just send me an email and I'll send them to your department.
Okay.
Dr. Carino?
Yeah. Thanks, Thyra. Very nice presentation. And just to let everybody know, our service here with diabetes couldn't exist without this service, without this great group of women down here. And I just want to personally thank you for all you do for our patients.
Thank you.
We are... It's a great service, and I just want to encourage everyone, especially primary providers, to use that service, especially with your new type 2s, your pre-diabetics. You know, you saw Thyra presented that there's getting to be better coverage for the pre-diabetics. There's always been good coverage for the Medicare population for type 2s. We are underusing that service. I use them a ton for type 1s. Like I said, it's been very, very integral part of my practice to have them assist with the education for pumps and sensors. Patients need that. We keep them busy with that, but I'd like the rest of you to keep them busy with the type 2s. Okay? So thanks again.
Thank
Just
you.
wanted to say thank you.
With the proposed wellness center, do you see yourself or your program having an office there?
Nobody has
goes through,
told me yet that I might have an office there, but we would love to be out where people can access the services easily. And I think that's probably, my boss is right there, so I'm pointing at her. But I mean, I think there's thoughts that some of our departments may have sites at that facility, which I think would be really great.
So I think they're talking about healthy cooking and meals and all that sort of
Exactly.
thing there, too.
Yep. Yep. All right. Well, thank you very much for coming. And if you have questions, I'll be down here for a little bit.